Good afternoon. I'm David Scott. I work in the Pacific Northwest in Spokane, Washington. I'd like to thank Mike Report and the co-chairman for inviting me to speak. I'm going to be presenting the results of a prospective randomized trial that I performed, comparing the clinical outcomes of a PS knee versus a medial pivot knee. I presented this at AUCUS last November, and it's subsequently been published in the Journal of Arthroplasty this year. These are my disclosures. The PS knee has been extremely successful, providing excellent outcomes. However, there is limited consensus whether non-post and cam cruciate substituting devices are an acceptable alternative. Possible advantages of non-PS implants include a simplified surgical technique with fewer steps, preservation of bone by elimination of the box cut, elimination of polywear of the post itself, and probably increased midflexion stability. This is a prospective, randomized, blinded, single-site trial comparing the outcomes of the Sphere to the Medacta PS knee. This system shares the same tibial baseplate and patella. They're identical, just the femur and the insert that differ. The primary hypothesis was that the clinical outcomes would be better in the medial stabilized group. These are images of the inserts and then superimposed on the right, and obviously you can note the deepened medial ball and socket geometry and the relatively flat lateral plateau. And this lateral view demonstrates, again, the increased articular congruency of the medial stabilized device compared to the PS. The femur in this system has 100% spherical single radius in both the coronal and sagittal planes, designed for high stability throughout range of motion. We used pretty standard, to be expected inclusion and exclusion criteria to try to have a tightly defined group of patients. We saw the patients preoperatively, 6 weeks, 6 months, and annually. We collected the Knee Society score, the Forgotten Joint score, and we performed a full X-ray series, including long-standing views for limb alignment. I performed all the surgeries with an identical kinematic alignment technique without boundaries. I used manual instrumentation, a tourniquet, medial patellar arthrotomy, and I evert my patellas. I did not use any sort of navigation or robotic techniques or MIS techniques, if there is actually such a thing for the knee, and nor did I use any PSI cut blocks. I cemented all patients, resurfaced all patellae, and sacrificed all PCLs. 99 patients received the PS knee, 101 patients received the medial stabilized. We had 192 patients following up at 6 months, 191 followed up at 1 year, and 171 at the 2-year point. There were no statistically significant differences in any of the preoperative characteristics, including demographics such as age, gender, BMI, the preoperative range of motion, the preoperative outcomes measures and alignment were all similar. There were significant differences in the inflection and in the Knee Society pain motion score and in the Forgotten Joint score, starting as early as 6 months postoperative. Additionally, the tourniquet time was about 3 minutes longer or 7% longer in the PS group. We did not see any differences in the Knee Society function score or in the coronal X-ray alignment at 1 year post-op. This is the Knee Society pain motion scores, 6 months, 1 year, and 2 years, showing the medial stabilized to be superior, almost a 10-point difference at 2 years, and these are all statistically significant. This is the Forgotten Joint score, which became statistically significant at 1 year and again at 2 years, showing about a 10-point difference between the two, favoring the medial stabilized at the 2-year point. And flexion followed a very similar trend, became statistically significantly different between the two groups at 6 months, and that carried through to the 1 and the 2-year follow-up points, about an 8-degree difference, favoring medial stabilized at 2 years. And again, all these were statistically significant. We had 3 DVTs, 1 PE, no infections. Excluding 5 manipulations, we had 2 reoperations. One was an ORF of a periprosthetic distal femur fracture at 5 months in a medial stabilized patient. And the second reoperation was a revision for aseptic loosening of a tibial base plate at 23 months in a PS patient. As hypothesized, the outcomes were better in the medial stabilized group, and there was also a shorter tourniquet time. The range of motion data reveals that rollback provided by a post-cam device is not required for excellent flexion. In fact, we found that flexion was substantially better in our medial stabilized group compared to the PS group. We hypothesized that the mid-flexion stability and anatomic kinematics of a medial stabilized device is certainly contributing to these improved outcomes. I also question whether the more anatomic approach to alignment and balancing, i.e. kinematic alignment, whether that is playing a role here as well. We do also have to ask ourselves and be cautious as to whether there could be any downside to the higher medial congruency of a medial stabilized device, such as perhaps long-term increases in aseptic loosening. I certainly think this needs to be evaluated carefully going forward in longer-term studies. I believe the data supports the use of a PCL substituting medial stabilized design as an alternative to a traditional PS device. The superior 2-year clinical results obtained with this medial stabilized knee, I believe, warrants continued follow-up, and especially further evaluation of other medial stabilized implants by other investigators. Thank you.